Hi, class. We're going to start week, week three, lecture 2. We're going to start with antiprotozoals, just a very short. We don't see that a lot. So it's not a big lecture. And then we're going to get into antivirals, which there's a lot to talk about there. Probably we could spend the whole week on that, but we're not. So without further ado, let's get into the process. So let me see I think this is, yeah, there we go. That's the first one. So no, that's not it. Is that the one? There we go. That's the one I'm sharing. Okay. So this, not very long, not a very long lecture. We'll just kind of touch on some things, just more of introduce you to some processes and potential answers, treatments, if you will. So your protozoa, these are your single-celled organisms. When I think of protozoa, the one that comes to mind is typically Plasmodium, or what we see in malaria. But broken down, you can have the amoeboid, and you might have heard of the Antamoeba histolytica, or the brain-eating amoeba. That's it. Very rare, but if you get it, it's pretty much 100% fatal. You have cilia, then those are the flagella species. So your protozoa, single-celled organism, those that are amoeboid, those are your Antamoebas. The big one is the species histolytica, but typically fecal oral and can lead to dysentery and some liver abscess. That's very important because you got to ask yourself, are you treating something that's luminal, or are you treating something that's systemic? Because that's going to help you decide what kind of therapy. No, nothing really discussed with the cilia. The flagella for sure. The big one here is the Giardia. I've never had this, but I've been around people. It usually has to do with being in the wild. My experience is being in the wild and drinking river water. That's a no-no. You don't want to do that. So, well, unless you filter it. Always carry your filter. Always filter your water. It may look clean, but it's not. But Giardia would be a big one. But human, dogs, cats, wildlife, and it leads to diarrhea. But when I say leads to diarrhea, it's profound and putrid. Leishmaniasis, we started seeing this back around 2004, 2005. It's from bites from the sandfly and was referred to as the Baghdad boil, because that's what it would look like. But you would get these soldiers were coming back with skin and mucocutaneous infections, and it looked kind of like, in a way, when you see chlamydia, or I'm sorry, syphilis type infections outside of the outset of being a STD, but like on the arm or something, you'd have those wounds that kind of looks like something with some granulation coming on, ulceration. But that was the leishmaniasis, and they didn't really know what was going on initially, but that's not uncommon to see. Certainly the trichomonas, which is usually an STD. It can be vaginal, it can be oral, anal sex can lead to it, but vaginitis and urethritis, and we use metronidazole for this, is what we use. And then the trypanosoma, this is spread through the kissing bug. So it says Latin American kissing butt. No, that should be kissing bug, I'm sorry. But it's referred to as Chagas disease or sleeping sickness, and this is why it's sleeping sickness and what happens. But so the kissing bug, a couple things have to happen. Number one, a lot of times the bite will be around your mouth because the sulfur smell, this bug, the kissing bug, is attracted to it. And the bug, though, has to bite you. So there has to be an entry point. Then the bug has to poop on that entry point. And then it has, so it's hard to catch, but then the inoculation will be with the trypanosoma. And if that does occur, you can have some acute illness, but usually it goes away. They call it the HIV of the Latin Americas because it doesn't affect you till 10, 20, 30 years down the line. And it's usually in the form of valve disruption. So you start having some arrhythmias and valvular heart disease, and that's what you get. But it's not going to happen overnight. It's going to happen down the line. But they call it the kissing bug, but you have to have inoculation. It bites you around the mouth because it's attracted to the bad breath, the morning breath, if you will. That's why it's sleeping sickness. So you might not even know what happened. And that's the problem. You don't know what happened, so there's nothing going on. And then your apical complex, these are your plasmodium, your cryptosporidium. Again, this is going to be more of a diarrhea, but this can cause a lot of issues, especially in the immunocompromised with systemic disease, as can toxoplasmosis. And again, this is more for cat feces. So someone who's immunocompromised or pregnant, they tend to say, don't change the litter box. So just something to keep in mind. But let's focus on the anti-amoeba histolytica. So this is fecal oral, and you can have symptomatic, asymptomatic, but the therapeutic agents that we use, you have to appreciate, is this just localized? Is it luminal, or do you need something systemic because you have liver flukes or something along those lines? And if that's the case, you're going to need something that usually is mixed, meaning it's going to be luminal and systemic, or you chase it with something that's luminal after you do systemic. But your mixed amoebicides, what we're going to do, it's going to be metronidazole. This is going to be your drug of choice for anti-amoeba histolytica. And again, very rarely is it a CNS infection, but when it does, it's certainly fatal. But we've talked about metronidazole and how it works, but it's forming a reduced cytotoxic compounds that bind those proteins and deoxyribonucleic acids or DNA, and that's going to result in cell death of that E. histolytica. So that's what you want, even if it's in the liver or it's in the lumen of the gut as well. But we don't need to really talk about metronidazole. We talked about that and the issues around it. Now, remember, this is a myth about if taken with alcohol, disulfiram reaction. I leave that in there, though, because I'm afraid there's going to be test questions on your pants. And so if you do see that question, I'd go ahead and say, yes, you can get what we call a disulfiram reaction. But the big one is going to be that unpleasant metallic taste that most will experience. And a lot of patients will have gastrointestinal complaints. So those are the two big takeaways right there. But just know this is a medical myth. You can take it with alcohol. But for test purposes, I leave it in the lecture because I don't want you to get dinged for it. But we talk about what's real and what's not real. When we talk about amoebas, the mixed amoebicides, again, you have tindazole. This is the second generation. Think about, when you think of tindazole, think about metronidazole. We just don't use it because it's more expensive, but it's very similar in how it works in its spectrum. But again, you can deploy this. It's very good for giardias or trichomonas and other infections that are going on. But it's as effective, but it costs more. And this is one where we do avoid alcohol consumption because you can get a lot of issues with the liver. So keep that in mind. But this is mixed as well, just as metronidazole is. Now, those that are just specific to the lumen, your ideoquinol and your paramycin, these are ones, number one, you would not take them long term because they have some pretty profound side effects. But they're luminal, but usually when you do this after you, excuse me, that just caught up on me. After you do the invasive treatment, then you need to do that for the extraintestinal disease, liver flukes, whatever. You can come in with a luminal agent just to make sure, in case you have some asymptomatic colonization, you can do something that's more concentrated and get rid of it. But Diadoquinol is nice because it's effective against trophocytes and in their cyst form, so probably might be a better option. I just don't deal with these. I'm just talking off these slides. This is not something I deal with. I've had buddies get giardia. I've never had it. I've never had the kissing syndrome or any of that. I don't know, but paramycin's another one, and you can see the side effects. Diadoquinol, the good thing, these are luminal. But there's certainly, you can get some absorption potentially, and you can have peripheral neuropathies. And again, optic neuritis. This is not something we use long-term because there's going to be some, well, it might not be able to be used systemically. You can certainly potentially have systemic side effects. So antiprotozoal medications, this is a nice chart over here that you can look. Asymptomatic cyst carriers versus diarrhea and dysentery versus amoebic liver disease. Again, you're going to be going with the metronidazole, plus you're going to chase it so you have those asymptomatic cysts living in your GI lumen and your GI tract. You're eradicating everything so it doesn't pop its ugly head at a later date. But systemic amoebicides, again, those extraintestinal, those outside of your intestinal tract. And again, the big one, intestinal wall and liver abscesses are going to be the big ones. That's what we're using these for. Chloroquine in combination with metronidazole, something you can consider to treat those amoebic liver abscesses. And then you want to get those trophocytes eliminated. But remember, that's the chloroquine's not going to be useful for luminal amoebocytes. So remember, follow with those luminal amoebocytes, and that's going to be your iodoquinone and your paromycin. But just appreciate those nasty potential optic neuritis and peripheral neuropathies and other issues that can come with the iodoquinone. So we're going to finish up with Plasmodium. Now, interesting thing. So back in the day, so we talked about syphilis. If you remember syphilis, they actually used to use syphilis, or back in the day, they used to actually use Plasmodium to treat syphilis. And what they would do, if you had syphilis, if you got neural syphilis, it was pretty much 100% fatal. And that was the problem. But syphilis is something that's heat labile. So when you have malaria, a Plasmodium infection, one thing you're going to do is you're going to have temperatures of 105 or higher. So they would actually give people malaria, and you would have these huge temperature spikes. And so I just told you that mortality was 100%. Well, what if I told you by infecting people with malaria, your mortality is only about 30%? So you still had about a 30% chance of dying. But the good news was this, is that it would cure the neurosyphilis. You were so hot that the tripomona would die, and you'd be cured of your neurosyphilis. And then as long as you survived the Plasmodium infection, you were good. So they would actually infect people with Plasmodium to treat neurosyphilis. Okay, well, if you don't treat malaria, won't that kill you? Yes. Well, back in the day, there was a product that now it doesn't work, but it's called quinine. They had quinine. And when you think of quinine now, you might think of something for soda, tonic water to take for leg cramps. We used to do that all the time, but they gave quinine. And so that's what they would do to kill the syphilis. They gave them Plasmodium, right? And then to kill the Plasmodium, they would follow it with quinine. And they went from 100% mortality to about 30%. So just because we think we have all the latest and greatest doesn't mean they couldn't get the job done back in the old days. But you know the process, it's mosquito-borne. And you have to know, so while it is Plasmodium, there's different species, and different species will infect different parts of the body, and different drugs will treat different parts of the body. So if it's something that will manifest in the liver, you have to make sure that it's a drug that will work in the liver and a drug that's sensitive to it. My point being is, you need to make sure you look at the current CDC guidelines and the guidelines of other countries. If you're going to Kajato, Kenya, you might take a different prophylactic anti-malarial than you would if you're going to Peru. You have to appreciate what species is there. The same when you're treating it. Is there endemic resistant in Kajato versus Peru? And you have to appreciate that. But anyway, the infected mosquito is going to deposit those sporocytes, and those sporocytes are going to migrate to the liver where they become merozocytes. So that's the problem. And then 3, these meros, they release and invade what? Red blood cells. Now, those with sickle cell anemia, that's an inherent protective mechanism, but sickle cell anemia, its own problem. So you're not going to get that if you have a sickled cell. Your red cell is not going to be, but you have another issue going on, but your red cell is not going to be invaded. But this is why you can get hemolysis and other things, and liver abscesses and such, so on and so forth. But they become merospectrotrophos in the red cell, and then again, they're going to multiply and they're released, but you do get hemolysis. The red cell is ruptured, and so they can affect other blood cells, and it just goes on and on. And then the mosquito picks up the other ones and spreads it to the next one and the next one and the next one, and so on and so forth. And you see the problem you get into, it perpetuates itself. But I'm going to refer you to the CDC websites. This isn't something you will see patients with malaria, especially those who traveled to endemic areas or places where you have high migration traffic. And you need to appreciate that, especially in the setting of Haemophilus and some liver issues. You need to appreciate that. Now, our treatments, Erelin, the chloroquine, it's losing its effectiveness. The side effects of these drugs are over here. The big one with chloroquine is the nightmares and the other issues that you can have in terms of CNS disturbances, but something to keep in mind. But it says this is the preferred treatment for uncomplicated malaria or Plasmodium falciparum. So remember, that is chloroquine sensitive. So that's very important. You have to look at the CDC website and see what are the chloroquine sensitive strains in the area you're going to. And if the majority are resistant strains, you need to avoid that. But the mechanism's not fully understood. But no doubt, GI adverse effects are real. The itching is there, headaches and blurred vision. If you're taking it chronically, you do have to get eye exams regularly. And you need to watch out for that QT prolongation, more specifically in conjunction with other drugs that can prolong the QT interval. But be on the lookout for those retinal toxicities. Again, the blurred vision, that's why we're doing routine eye exams. Watch out for those hematologic disturbances and those movement disorders you may see, and so on and so forth with the cardiomyopathy, hypoglycemia, and muscle weakness. But clinical pearls, we do avoid it in patients who have psoriasis, porphyrias, or pre-existing auditory disorders or seizure disorders. So, but this is a good way to keep an eye on all the potential side effects of chloroquine. This is a big one that pretty much, for the most part, the atovaquone proguanil, this has maintained its effectiveness and is used quite often. Malarone for both prophylaxis and treatment, but I would consider, if you're going to say this is preferential treatment, no doubt, when you have chloroquine resistance, this is what we're going for with the Plasmodium falciparum. And most places you still maintain sensitivity, but there's your mechanism of action. With the atovaquone, it's going to be a mitochondrial process, and the proguanil is going to prevent DNA synthesis and subsequent death. But pharmacokinetics, we do take it with food to enhance GI absorption. I think this is something very important that you need to emphasize. When we were in Cajado, I always took mine with food. I think I missed most of my doses, it seemed like. But it was the dry season, and I never saw a mosquito, but you got to be careful. I did miss a couple of them, though, because I was having GI irritation, I felt like. But your common adverse effects, the nausea, vomiting, diarrhea, mine was more nausea and abdominal pain. And I felt like the headache part, I felt like it was more of a mild headache. I had no problem with hunger, so I had no problem with dizziness, but I did have some more, I'm going to call it slight nausea, and that's what's going to lead to the anorexia. It's not an appetite suppressant. It's more of the GI side effects that naturally create an anorectic state where you just don't want to eat. But you certainly have to watch those ALTs and ASTs because you can have an increase. But if you do, they do normalize after 4 weeks of treatment. And I guess I had, when you take it, they say you start a certain time before you leave, maybe 72 hours. I can't remember exactly. But you typically take it for 7 days after your return, just because that process that we illustrated starting this discussion can be ongoing. So anyway, I'm going to leave that there. I know it's not a lot, but yeah, antiprotozoals, you're going to see it, and you're certainly going to see the diarrhea type diseases from some of those protozoals. So I'm just writing down where we started, antiprotozoals, and where we're going to finish. I got my timer going. So we're going to do that, and screen sharing stops. I want to make sure that I get the right one pulled up. So we have the, the right lecture. Now we're going to go into antivirals, and I'm not going to get into a discussion of it like Paxlovid and things. I'm not going to go there. If it has to do with the coronavirus, just Google it. I don't think there's a therapy that works, including Paxlovid, but I don't want to get into that discussion. So I'll leave it at that. So Zoom, let's share our screen, and antivirals, antithelmintics, your worm medication. I do have a site called FarmFacts. I may pull it up as we go along and share it when we're done. But here we go. Antivirals, anti-hepatitis C, hepatitis B we can control. We can cure C, HIV medications to get CD4 counts up where they need to be, and zero viral load, which is what we want. But our objectives by now. So antiviral drugs, we're going to start with influenza, but we'll talk about herpes and cytomegalovirus. We'll discuss HIV. The big one there are going to be your nucleotide and nucleoside reverse transcriptase inhibitors. You want 2 of those, and then 1 integrase inhibitor. So for the most part, when you think about treating HIV, this is your 2 main classes. Hepatitis B, again, your nucleotide reverse transcriptase inhibitors, and then interferon. This is one we can control. Some people self-cure, some people self-remit, but it's not curable, so to speak. Hepatitis C, that's a whole different discussion. The C now stands for cure, and that's a beautiful thing. And as little as 8 to 12 weeks of therapy, but we'll talk about NS5A inhibitors plus those protease inhibitors, and then the NS5B RNA-dependent polymerase inhibitors. So let's get started with influenza. So first of all, amantadine and rimantadine, these were used more for movement type disorders. But one thing I want to point out is we no longer use these. These were only effective against influenza A, first of all. That's the first thing. The second thing is they're inherently resistant. So they're no longer utilized. The worldwide resistant is pretty much 100%. But how would it work? It would block viral uncoating of influenza A specifically. It did not work for B, and of the integral membrane ion of channel M2. So it would kill it. But adverse effects, the reason I say we'd use it if there was movement disorders, we could use it as an anticholinergic in like Parkinson's disease and things such as that. So, but remember the adverse effects were profound, especially in the elderly. Can't poop, can't pee, can't spit, can't see. So keep that in mind. CNS, we'd have agitation and anxiety, some ataxia, confusion, delirium, irritability. And a lot of times these were deployed in nursing homes when there was an outbreak of influenza to try to prevent the spread. GI, you can see the GI side effects, and then dry nose, which that ties directly into everything's going to be dry. So that's the main takeaways from amantadine from historical discussion, but there's no reason to prolong the discussion. Your neuraminidase inhibitors, that's a different story, and your big one's going to be Tamiflu, the oseltamivir. This is oral. This is the one that some of you have probably taken. If it's up to me, I when it's offered, if I have the flu, I don't take it. I think if you do get on it within 24 hours of your first symptom, I think maybe you can see a benefit, but it comes with a lot of gastrointestinal side effects, and that makes it prohibitive because a lot of kids especially can't tolerate it. But these can be used for both influenza A and B. So that's a big difference. Even if amantadine worked, we have a good mix of A and B in our outbreaks. The other one is Relenza. This is inhalation. Zamamivir, and then the Repavab, the Peramivir IV, which is usually just a one and done dose. So the CDC will give you guidance. It's a good place to go when we have all these infectious disease outbreaks, and they have the influenza map where the different colors. This is widespread outbreak or vary, but usually around October, November, it peeks its little ugly head out, and all communities will go through their outbreaks or their high season, and it varies from geographic area to region across the country. And then come about March, April, May, it just goes away, and we see it again in the winter. But it is a year-round viral infection. It's not just overnight. But how do neuraminidase inhibitors work? Well, the easy answer is they're inhibiting neuraminidase, but when you have an infection, the virus is going to insert the neuraminidase into the host cells, and this causes the release of those virons, and you can see it right here. So boom, what's going on there? So giving these neuraminidase inhibitors such as Tamiflu, in essence, they inhibit the enzyme, and it prevents the release of new virons. And if you prevent the release of new virons, you can't have spread from cell to cell and continue to propagate and replicate. So think of it this way. The virus remains stuck on the surface of the cell, inhibiting propagation of infection to other cells. So you can see it right there. There's the neuraminidase inhibitor. There's nothing to break it free. And the neuraminidase is what's cleaving the viron from that receptor. So replication is blocked. It just dies. But again, the efficacy, it's been proven, but it's not anything impressive. Here's the dosing, the treatment for 5 days. You all can look at that. Just know we do renal dose adjustments for those that have creatinine clearances less than 60. We will start making renal dose adjustments. But you do have chemoprophylaxis, and this is something to consider. I have done this before, but again, this is going to be in your children in this case. And then when you get up to adults, 40 kilograms or all 75 milligrams twice daily, which is something to keep in mind. There's the inhaled Zanamivir. I don't know if that's even on the market. The Peramivir is, but we'll give oral in the ICU through the suspension, or if they're not intubated, we'll give it as the capsules. But this is usually just a one-time dose that we give it, and typically 600 milligrams. And again, you can repeat the dose in some cases, just depends on the situation. Now, if you're really, really sick and you're in the ICU, even if it's been a while since you've had the flu, it is recommended to start it if you want to. You don't have to, but we will go longer than 5 days. This is more of your outpatient considerations, but you can take that Tamiflu. There's also Tamivir with food that can help improve the tolerance. And remember, I mentioned a lot, especially young patients, will have a lot of GI intolerance to the point of not just nausea, but actual vomiting. And you can open the capsules. It comes in a suspension, but you can open the capsules to be used or administered through a nasogastric or oral gastric tube or a PEG tube if need be. It is hepatically metabolized, but there's no dose adjustments required. We don't know about severe impairment. Why? It hasn't been studied. You do have to appreciate renal dose adjustments, though, with also Tamivir and the Peramivir. Remember, the Peramivir is the IV formulation, but I think that the dose adjustment starts at 60 mils per minute or less for the creatinine. So just keep that in mind. And there are no drug interactions. But again, these drugs aren't necessarily proven to be that good. The adverse effect, the big one is the GI, and the headache is no doubt there too. But the big one, when we talk about nausea and vomiting, usually it's more of a nausea phenomenon. But this is a drug that truly has a lot of vomiting. And then the Zanamivir, again, headache, sore throat, respiratory infections. Remember, this is inhaled. So it's inhaled. So you're going to have a lot of those issues that come, oral pharyngeal or pharyngeal and for larynx and bronchial type issues. So we usually would not use this in patients with asthma or COPD. The neuropsychiatric events, this is real, and it's just another adverse event. These two are big with these drugs. Again, I'm not a fan of them. If I had the flu, I wouldn't take them. They've only been shown really to decrease symptoms by 24 hours. But clinical pearls most likely effective if taken within 48 hours of symptom onset. Now remember, like I said, if you're critically ill, we will initiate neuraminidase inhibitor therapy regardless of the onset of time and go until clinical improvement. So it could go more than 5 days, just FYI. And then the baloxavir, this one here flows a little bit different mechanism. This is an endonuclease inhibitor, also effective for influenza A and B, but it's PO, and it's a one-time dose, but baloxavir. And how does it work? You can see there the 5 stages. So your neuraminidase was happening over here. You would block the neuraminidase, you'd inhibit the neuraminidase, and you couldn't cleave the viron from the cell, so you didn't have this exocytosis and viral replication. Here, when you talk about the stages of the cycle, again, we talked about that M2 ion channel, right? And uncoating viral entry, all the things going here. Here's where Zofloza works. This is working on that viral replication. So the virus, when we talk about neuraminidase inhibitors, it's already been replicated. We're just not letting it free to do more replication and invasion of more cells. So that's the specific. When we talk about endonuclease inhibition, we're actually arresting viral replication. So here's the recommendations for specific agents, specifically the oral baloxavir, but there's the treatment 12 years and older. I can say I have seen it used in younger than that. So not a lot of adverse effects. I think this is probably a better option, a cleaner agent. It's something that I would possibly consider taking over the other ones, but mainly because the less adverse effects. But you can have some of the GI effects, but not like you do with neuraminidase inhibitors. So this is probably a cleaner drug. Again, it is a prodrug, which its conversion you can see there. Not studied in those less than 50 mils per minute creatinine clearance, so avoid use. But the thing is, it doesn't mean you can't use it. It just means it hasn't been studied. So you're going to make your own decision. You do have to give it separate of dairy products that can chelate those calcium type products, so those divalent cations. So that's going to put antacids into the mix as well. It's not that you can't drink milk or take in antacids. You just need to make sure you separate it 2 hours before, 4 hours after. But it's going to be a one and done, and you're done with it. Herpes infection, so pretty common, whether it be just a fever blister or something more sinister. That they're all lifelong, but something like genital herpes and encephalitis, which are can be from an STD to a true encephalitis. Which encephalitis, if you don't treat it, it no doubt can be fatal for sure. That's why when we're ruling out meningitis and we haven't had our cerebral spinal fluid draw yet, that's why we always, before we see our protein count versus our glucose count, and is it predominating as leukocytes or lymphocytes? What's it predominating at? And that's always important. Neutrophils or more lymphocytes. That's going to help with bacterial versus non-bacterial, and that could be fungal in nature, and it could be viral. But that's all important. That's why we start acyclovir in those cases as well. But that's going to be your workhorse, is acyclovir. And it comes in IV and oral and topical. So there's a lot of routes to give it. But the spectrum of activity for all of these, your famciclovir and your valacyclovir, which is a prodrug of acyclovir, these are going to be herpes, both zoster and simplex, your varicella zoster, and then in cytomegalovirus, more along the lines of valacyclovir. So infections that we preferentially treat with acyclovir, it's going to be your herpes simplex virus. This is going to be HSV1 and 2, genital herpes, and then encephalitis. This is the treatment of choice. It can be just mucocutaneous, a fever blister. It can be your herpes zoster, which is just a reactivation of your chicken pox, if you will, shingles, and then your varicella zoster virus. So that's where you see acyclovir, but the mechanism is pretty similar for all these. Your acyclovir is added to adenosine triphosphate, and you have thymidine kinase, and here it is right here written out, but metabolized to acyclovir triphosphate. You can see that right there. And then you have inhibition of viral DNA polymerase, and valacyclovir has the same thing. Famciclovir, very similar, except it converts to pencyclovir triphosphate. But the end game is viral DNA synthesis is inhibited through inhibition of these various enzymes, such as HSV DNA polymerase. So that's how they all work the same. This is really what you need to know when it comes to the pharmacology in terms of a mechanism of action. So the pharmacokinetics, again, acyclovir can be an IV infusion, topical or oral. We usually give it over 1 hour to prevent kidney damage, because you can get crystal urea, some precipitation of crystals in the urine, and that can lead to some kidney damage. And we always assure that we have appropriate hydration. You get very good distribution into the CSF. Now remember, there's not really a herpes in meningitis. This is a true encephalitis. So this is encephalopathy type things of the actual brain lining. So something to keep in mind, but it is renally excreted. So you do have to appreciate renal dose adjustments when you're giving patients acyclovir. No major drug interactions to worry about, which is always nice. When it comes to adverse effect, topical, really nothing other than potential for skin irritation. With the PO and the IV, no doubt you can have some neurotoxicity and confusion. The renal dysfunction, we defined it, and we see crystal urea, hydration is the key. But the neurotoxicities, headache, simple headache, to other types of issues. But the IV, again, renal dysfunction. You can have some infusion, irritation in the vein, phlebitis. Extravasation can be detrimental. It can be a problem, not detrimental. And then, of course, the risk of neurotoxicity is there. But these agents are effective during the acute phase. So with any virus infection, sooner is later, or sooner is better than later. You have to maintain adequate hydration to prevent that crystal urea. And then the oral treatment often requires dosing of 5 times a day. That's why valacyclovir became a nice alternative, because you don't have to dose it as often. And then the mechanism of action for valacyclovir, again, the spectrum's the same, HSV1 and 2 and varicella zoster, but we also add cytomegalovirus to that mix. It's used quite common as an oral. but it's a prodrug of acyclovir, which is converted to acyclovir in the liver, but the spectrum is the same. The mechanism of action is the same as well. So again, cyclovir cytidine, this is one we use for cytomegalovirus and cytomegalovirus retinitis. Now, it is inhibiting that viral DNA polymerase, which we talked about on the previous slide. But one thing you got to watch about ganciclovir, there's also a valganciclovir that we use for CMV. We don't really use valacyclovir and acyclovir. This is not what we go to for CMV. We like the ganciclovir products, but there's also a valganciclovir that we use. This is IV here, but it does come with profound bone marrow suppression risks, such as neutropenia and thrombocytopenia. So you're monitoring your CBC, no doubt, and this is real. But when you have CMV retinitis, a lot of times it's going to come along the line of a transplantation of an echinacea CMV that way, or HIV patients, or those who are immunocompromised when we start talking about retinitis. But CMV in general, you have to appreciate that. But just remember, there is a valganciclovir. Human immunodeficiency virus, again, you can go through here the HIV life cycle just as easy as I can, but you need to do this and look at how it binds fusion inhibitors. We have drugs that work there, right? Binding fusion. We have the reverse transcriptase inhibitors. We have the integrase inhibitors. These are the two big areas where we work. We do nucleoside or nucleotide reverse transcriptase inhibitors and integrase inhibitors. This is a big part of what we do. There's the protease inhibitors, but you need to go through there and appreciate this life cycle of human immunodeficiency virus. I'm not going to go through it with you, but this is important because this is how it gets incorporated back into our DNA with transcriptase processes to get into DNA from RNA and vis-a-vis. But it's good to know because this is how we know how to treat it. Now, you can see the different types of therapy. These are all very well understood. The reverse transcription inhibition is big and integration is big. These are the two big ones that we do. So these are all good, the ways to attack these, but these are the two NRTIs and one integrase inhibitor, a 3-drug combo. There is now 2 drug therapies now for certain situations. Once you get your CD4 count and stuff where it needs to be, there's an IV HIV medication that I think you can give just once every 6 months. It's continuing to expand, but we're just going to cover general principles. There's no reason to get out of control with this because it can get very detailed. But they do keep the guidelines up to date. Constantly changing, not as much. They did change different situations. It was extremely complicated. And when they finally said just 2 NRTIs and an integrase inhibitor, you're good, that simplified everything. So it's not as complex as it was. So patients will be on at least 3 drugs. That's not the case anymore. We now have 2 drug regimens of what we call HART therapy. And HART stands for highly active and antiretroviral therapy. So the considerations for treatment, you will get a culture, well, you'll have but you will get a sensitivity panel. So which will help you understand which drugs are going to be efficacious. And that's going to go along the lines of resistance. Are you treatment naive? Are you treatment experienced? It's very important that you have good compliance with these drugs because missing doses or not going with your whole pill count can lead to induction of resistance. That's why it's important. A lot of these new drugs have all 3 combinations of what I just mentioned, 2 NRTIs and an integrase inhibitor, all in one pill that you take once a daily, so it has ease of use. Cost is not as much of an issue because we have government programs that can help people get their medications. Drug interactions is big. The big one is you have a patient that is their CD4 count is 300-400 or higher. Their viral load is not detectable, and then you put them on a drug that induces the metabolism and they're subtherapeutic, and the next thing you know, they have a viral load and their CD4 count's going down. So anytime you're adding a new medication to a patient and they're on an HIV medication, it behooves you to run those tests, an interaction test to make sure. Comorbid states, always got to look for that, CHF, pregnancy, whatever it may be, you got to appreciate that. And then you got to appreciate the adverse effects. A lot of them revolve around neuropathies and a lot of them revolve around GI side effects. So sometimes maybe punting them to not necessarily an ID doctor. I don't think that's necessary, but punting them to an HIV clinic if you're so lucky to live in a town that has one. So PrEP is very important. This is pre-exposure prophylaxis. This is Truvada for prevention of HIV transmission. Some will take it continuously. Some will have a pill in a pocket. Probably if you're high-risk behavior, your pre-exposure prophylaxis, I'd recommend taking it daily. This is a combination of tenofovir and emtricitabine, so 2 NRTIs. So your classes, there's your nucleoside tied reverse transcriptase inhibitors. This is a big one that we like. Now the guidelines say have 2 of those. These are also used, don't get me wrong. Fusion inhibitors, integrase inhibitors, PIs, entry inhibitors, antivirals, but these integrase inhibitors, this would be one of those. That'd be the next, like bacticavir or something like that. There's several. So again, now the treatment guidelines, and they haven't really been adjusting, but your 2019 guidelines, first-line regimens for antiviral, antiretroviral naive patients would include 2 NRTIs plus an integrase inhibitor combination, or a combination of 1 NRTI plus an integrase inhibitor may be an opportunity for some individuals. Again, this would just be the 2 dose, and the drug's out there. But you have HIV copies greater than 500,000. You have an A hepatitis B co-infection. You really wouldn't want to go that route because your viral load's high and you have a co-infection with HIV. So starting ART therapy, antiretroviral therapy, you got to wait till your you can reactivate your hepatitis B if you have a co-infection with some of these drugs. So you got to be really careful. So let's talk about these. The initial regimens for most people in HIV, and these have good virologic efficacy and they're tolerated. So they have nice toxicity profiles and ease of use, but you can see the brand names. This one here's dolutegravir, abacavir, and lamivudine. So your integrase inhibitor and your 2. Abacavir now is very important. Abacavir, you do have to do HLA-B allele 571 testing because you can have some pretty profound reactions to these drugs if you carry this allele. So it's something you have to be negative. So just know with abacavir, you do have to do genomic testing. Okay, I'm going to say that again. With abacavir, you do have to do genomic testing. But another one is this is just all 3 meds in one. The one I like is Biktarvy because it has your bictegravir, emtricitabine, and tenofovir alafenamide. This is nice because you can use it in lower creatinine clearances, but this salt form of tenofovir, but also this TAF, this salt form of alafenamide brings more metabolic issues, so heart type issues. But again, you have an integrase inhibitor and 2 NRTIs. And then, of course, here's one you can do Tecvicay, Truvada, or Descovy. That's another one that's a 2-drug regimen, but you can see these here. The various products that we have out there that we can use, and more come out. These are your nucleotide reverse transcriptase inhibitors as individual products. Fortunately, now these come in combination, but remember the abacavir NRTI, this is the one that you got to do the B allele 5701 testing before you give it. But this gives you an idea. There's the emtricitabine, there's the lamivudine, stavudine, that was AZT, and zidovudine we don't use as much. These can turn you from a eukaryote to a prokaryote, turn you into an anaerobe. And I've actually seen that. Profound metabolic acidosis and death over 24 hours. Here's your tenofovir disoproxil. We like to use the alafetamide salts now because it's you can use it with a creatinine clearance down to 30. This one was 60, the disoproxil. But the problem with the tenofovir alafetamide is you get one benefit and you lose another, and it can cause a lot of metabolic derangements. So the NRTIs, whether it's a side or tied inhibitors, you can see once that viral RNA is released into the host cell, it's going to have to go on, it's an RNA, so it's going to have to go under transcription to a DNA cell. So that's where reverse transcription comes into place, reverse transcriptase, and that's what we're inhibiting with these drugs. So in essence, we're not allowing the RNA to convert to a double-stranded DNA. We're inhibiting that step. So it's blocking reverse transcriptase. And the NRTIs, they inhibit the action of that enzyme. And what does that do? Prevents DNA synthesis, so it can't replicate. That's as simple as that. So the NRTIs, so ADME, they're renally excreted. So all of these will require renal dose adjustments. Always remember the exception though. Abacavir doesn't, but the thing with abacavir is if you're positive for the allele, the HLA-B allele 571, you can have profound hypersensitivity reactions, end organ damage, all kinds of stuff. With abacavir, you're going to do it. But just know all these are renal dose adjusted except abacavir, but abacavir is the only one you have to do pharmacogenomic testing on. So keep that in mind. The class effect, the lactic acidosis, hepatomegaly, GI disturbances. When someone gets post-exposure prophylaxis, you usually get some Zofran with it because they're going to be on it for 30 days. The GI side effects, they wane, they go away, but for the first 2 to 4 weeks, it can be profound. Now, some things to point out. The lactic acidosis is more with the stidovudine. We mentioned that. We don't use that. So abacavir, I gave you the exception. You don't renal dose adjust, and you got to make sure they're not positive for the 5701 allele. The emtricitabine, you need to understand, appreciate hyperpigmentation of the soles and the palms. The mivudines we'll tolerate it. We don't use it as much though. We use more emtricitabine and tenofovir alafenamide. But so I need you to know this though, tenofovir disoproxil, which we abbreviate TDF, this can lead to osteoporosis or decreased bone mineral density, and it can have some issues in renal dysfunction, specifically creatinine clearance less than 60. That's not the case with tenofovir alafenamide. It doesn't have as much effect on bone mineral density. It doesn't have the effect on renal dysfunction, but it comes with increased lipid issues, so dyslipidemia, both good and bad. So you need to, and that's why the Y for the TAF, the alafenamide, it has less proximal tubule wasting, and there's less bone mineral density changing, but less lipid lowering. So there's a good and the bad. Now, you need to, if a patient is on these and they're co-infected with hepatitis B, just know if you withdraw these medications in those patients, you can see a worsening of their hepatitis. So it's no doubt something you need to appreciate and understand. So let's go to the non-nucleoside reverse transcriptase inhibitors. And this isn't something we see much, but these are the products. You can review them. Efavirenz is the one we see the most. That one comes with some, it can make you feel freaky and psychiatric stuff, so we try to avoid it. But again, it's a non-nucleoside reverse transcriptase inhibitor. Again, the process is the same. The main difference, if I had to say what's the difference between an NNRTI and an NRTI, is these don't require intracellular phosphorylation. That's really the biggest difference, but the outcome is you're preventing the synthesis of the DNA. And there you go. The main difference compared to an NRTI is they do not require intracellular phosphorylation. So that's something you want to appreciate and understand. Now, these here, so with the NRTIs, again, lactic acidosis is a big thing. But also another thing you can get into with these is when you take PPIs and things like that, it can start causing some absorption issues. So you have to appreciate that. But with the efavirenz, the thing I think of with the efavirenz are those CNS side effects and the abnormal dreams, impaired concentration, psychosis, even suicidal ideations. I think that's what you have to appreciate with the efavirenz. And certainly fomentin hepatitis, you can have hepatic failure. We don't use in child P, B, or C. We give it on an empty stomach. And then if you give it at bedtime, this is the big thing, these psychiatric related adverse events, we give it at bedtime to try, hopefully you sleep through it. The ribavirin, again, hepatotoxicity, QT prolongation, the CNS effects are there. This one we take with meals to increase absorption, but we don't use this. If your viral load is 100K, over 100K, your CD4 count is less than 200, this is one we don't use. Remember though, We're doing more of the NRTI plus an integrase inhibitor, but this is one we don't give with the PPI, and we take it with meals to increase absorption and to have acidity in the belly. So this is something you need to appreciate and understand the differences between these two. Your protease inhibitors, you can go through them. These are going to be more on the NS5. Ritonavir, those of you who are familiar with Paxlovid, this is the booster in there, ritonavir, but these are protease inhibitors. And you can see there's a long list of them. Used to, this is all we had. And patients with HIV would have this pill load of like one of each. And 3 times a day, they'd have 9, 10, 11 pills to take just for their HIV. It was horrible. But now we're on the end of the cell. So you have your maturation after viral release. So these are your protease inhibitors. So this is where you're going to get that cleavage of the polypeptides in assembly. That's where the protease inhibitor comes in. Well, we're going to inhibit those protease enzymes, and that's what's responsible for that maturation and release of those viral products. So we're inhibiting the production of non-infectious virals. And so that's the rationale between protease inhibitors. Now, when you're going to start getting into NRTIs and PIs is when you get your sensitivity panel back. And the way it works, it's weird because you'll see like an N by a drug or a Y. And you got to be careful because Y means yes, there's resistance. No means no, there's resistance. You would think yes would mean, yeah, use it. So you got to make sure when you're interpreting, you read what the interpretations mean in terms of how they are labeled, because that's how it used to be. I haven't seen one in a while, but that's how they used to be. So you need to appreciate that. But again, there's the mechanism, but these protease inhibitors, and again, these class effects, you need to appreciate them. PIs have a lot of metabolic derangements. You've got to appreciate that, and they have major, major drug interaction issues. You've got to appreciate that. So something to keep in mind. But atazanavir and darunavir, those are your 2 big ones, and you can read through these and appreciate, again, drug-specific, the benign hyperbilirubinemia, which can lead to jaundice and cholestasis, and kidney stones. This one has the lowest risk, though, of hyperlipidemia, so something to keep in mind. And the darunavir, things like this, always give with ritonavir. We got to boost this one. The sulfur so those are things to keep in mind. You can see with these drugs, it's just if you're in a situation where you're the only person available to treat HIV, go to the CDC website or go to the HIV websites, and they will tell you exactly what you need to do. It'll give you a step-by-step calendar on what you need to order, when to do it, how to do it, and then how to treat it. So don't think, but you want to get treatment on as soon as possible. You know, these patients, I guess maybe if they have an active CNS infection, you kind of want to cool it off because you can get some major encephalopathies, and no doubt you can get some inflammation and increased intracranial pressures, like a cryptococcal meningitis in an HIV patient. But you can have immune reconstitution syndrome. And in essence, when you start giving these drugs, their immune system starts to come back. And it's like, oh, wait, look at all these antigens or these bad guys. And they start killing everything at once. And you get that and you feel horrible because your immune system's working and it's killing all these pathogens. Well, if it's in the CNS, you can see that's a problem. But for the most part, the old terminology was you wait. When your CD4 count got to a certain level, you'd start therapy. That's not the case anymore. You want to start therapy immediately if you can, because those cell lines that make CD4s, your T cells, your T lymphocytes, and so on and so forth, those cell lines, what they found out is they don't regenerate. So if this is all your cell lines, and this one's been killed, this one's been killed, and this one's been killed, if you start therapy sooner than later, you've preserved all these. So maybe you can successfully have a CD4 count that's always greater than 200. But if you wait till your CD4 counts in 200, the killing continues. In these cell lines, you can't have differentiation in your marrow, and you might not ever get above 200 again. So we start therapy immediately in HIV. These are integrase inhibitors, so these are available as individuals. The Centris was common to be given with Truvada, but now we have recombination products, and the big one is with Bictegravir, and that's going to be with emtricitabine, Biktarvy, and that's going to be with emtricitabine and tenofovir. alafenamide, not the disoproxil, but the alafenamide. So that's good. And have these integration inhibitors, again, integration into the cell to get back to RNA. So it inhibits the insertion of proviral DNA into the host cell genome by occupying the active site of the enzyme for the integration process. So it blocks viral DNA integration into human DNA following that reverse transcription. So it's there on the next step, and that way you can convert back to RNA and you don't get viral release and continued maturation and replication. So integration inhibitors, no dose adjustments. Now from a class effect, CNS effects, so insomnia, depression, suicide ideation. So you need to appreciate that. It is more common in patients who have pre-existing psychiatric conditions, and you can also get some rashes with this. But the dolutegravir, just picking one drug out, increased creatinine phosphokinase with associated rhabdomyolysis and increased LFTs. But these you can read through. But this is a very nice class of drugs, and they are first-line therapies for sure, in combination with two NRTIs. Your entry inhibitors, your Fusion versus your Maraviroc, subcutaneous versus PO. We don't see these as much. They're very expensive, but this is the very first step. This is just fusion. So for the virus to bind to the host cell, conformational change occurs at the GP41, and you can see it down there. And with these medications, when you have the binding to the GP41, that prevents that conformational change. And you don't get membrane fusion of HIV to our CD4 cells. So pregnancy, we don't use it. In the injection site, you can get subcu nodules and then, of course, nausea and diarrhea. But yeah, it's pretty simple. That's why if you understand the life cycle of how these work, you can see where these drugs nicely fall into place when it comes to HIV. Now, the CCR5, that's the Maraviroc, or Maraviroc, however you want to say it, but this blocks the CCR5 co-receptors. And this is going to assist with the entry of the virus into the host cell. So you have your HIV, so it can express preference for either the CXCR4 or the CCR5. So you have to determine the preference with testing prior to using this therapy, because if it's a CXCR4, no good. And you have to watch for those drug interactions, specifically the 3A4 isozyme of the cytochrome P450 system. There's your most common adverse reactions, but rare you can have acute cardiac failure, and there can be some Stevens-Johnson syndrome as well. So something to keep in mind. These are rarely, if ever, used in my world because this is going to be more of a clinic, and I don't think we have clinics in Abilene. I think it's going to be your bigger cities. So the NRTIs, absolutely. And the integration inhibitors, yes, those are the ones that in my world we'll see come into the hospital, or we'll make recommendations for it. But if you want to get to some of these more advanced drugs, if you will, you're going to have to be in an HIV clinic in a bigger city where there's possibly more resistance. Resistance can occur anywhere. So anyway, when I speak to these drugs we're talking about now, fusion inhibitors, entry inhibitors, this is just not something I have a lot of experience with. The other ones I do, including those metabolic derangements that you read about and how we handle them. But I'm telling you, when I remember when HIV first came out, these patients, they were pretty much, it was a death sentence. That is not the case. Patients with HIV live their full life now. So it's something to appreciate and understand. So, but you can read through these and go through them with the entry inhibitors. Again, with the Maraviroc, you do have to make sure that it's the CCR5, not the CRX. So the antiretroviral boosters, again, cobicostat is one, and the ritonavir. The cobicostat, now ritonavir does have antiviral activity, but cobicostat does not. But this is just it allows you to give more drug give the drugs less frequently. So that's when you'll see cobicostat added to the combination, but it's just a booster. It blocks metabolism in some form or fashion, but does not have antiviral activity. Now, real quick, I want to just focus on some of the opportunistic infections. This is something from a pharmacist perspective, probably play a bigger role in, not necessarily in the hospital because you're not going to be exposed to these, but we do see patients come in who have these, and we're part of the treatment team. But those opportunistic infections, so you have the three big ones to worry about. That's going to be pneumocystis jirovecii pneumonia, which you'll see referred to as PCP. It used to be pneumocystis carnii. Certainly toxoplasmosis, your Mycobacterium avium complex, and those are your big three. What you do need to know, though, is you need to memorize what are the CD4 counts where you need to begin prophylaxis. Now, and what drug you prophylax with. Now, keep in mind, when you treat these, there's a lot of differences. Has the patient had this before? When do you DC it? When the CD4 count is greater than this for a month, or whatever that definition may be. There's different times when you DC it. Sometimes it might be a lifetime if you've had the drug. But when do we start prophylaxis? When your CD4 count drops below 200, that's when prophylaxis starts. And the first one is going to be PCP, your pneumocystis, and we're going to use sulfamethoxazole and trimethoprim or Bactrim. That's what we're going to use. When your CD4 count gets to less than 100, that's when toxoplasmosis comes into play. Not a problem. Why? You're already on your Bactrim. So you can see there your sulfamethoxazole, trimethoprim, your Bactrim, that's going to cover your PCP and your toxoplasmosis. So if you're doing it right with your CD4 count less than 200, you cover the toxo anyway. MAC is when the CD4 count is less than 500. Now, this is when you're going to add the azithromycin to the table. So you can see here, though, CD4 less than 200, PCP with TMZ, you're covered. TMP, your CD4 less than 100, toxoplasmosis, you're covered. And then you would add the azithromycin. So yes, you do need to know this. It's very important. You need to appreciate it. Okay, hepatitis B and C. Let's jump into this. So here are your tables, your drug dosing tables for hepatitis B. Now with B, we can't use the C word cure, but you can see the drugs you know with your interferon products. That's going to make you feel like that you've been hit by a freight train, you have the flu, it's horrible. So you do need to know when I say interferon, flu-like symptoms, fatigue, mood disturbances, just feeling bad. You're going to have to monitor a complete blood count. You need to know this. All this is important. There's the tenofovir that we talked about. You need to understand that, and the tenofovir alafenamide. So if you have a patient with this co-infected with hepatitis B, it behooves you to use a product with tenofovir. So maybe Biktarvy would be a great option. So the emtricitabine plus tenofovir alafenamide in addition to the bictegravir would be a good option. So the interferon alpha, so poorly understood mechanism. We typically use the pegulated formulations because you can give it less frequency because the fat bubble around it delays the absorption, so there's slower clearance. We do administer it subcutaneously. If it's the PEG form, we give it intramuscular as well. Drug interactions, no major one, but the big thing here is the adverse effects, and there are many. And the big one is going to be the flu-like symptoms, and they can occur within 2 hours of your first dose. Also, GI disturbances, people tend to lose a lot of weight. The anorexia isn't necessarily due to the drug causing a lack of appetite. It's because of all the abdominal issues it causes. You are checking CBCs because of the bone marrow suppression that can occur. You can have some autoimmune issues with it. You can have hepatic disturbance with it. You can sure have CNS effects with it, depression. A lot of it's going to tie into all this other stuff, though. Is it really causing? Is this the causation, or is it just a correlation with all this other nasty stuff? I'd feel better too. You can have hair loss with it and undescribed rashes, but the good thing is we no longer use this in hepatitis C first line. That's the good news. But hepatitis B, yeah, it's still out there. So we'll focus on hepatitis C. So this is a good thing because C now to me stands for cure. So there are key targets. So cell entry, it uncoats. You have an rRNA genome in the cytoplasm, and the RNA is translated into a polyprotein, which has smaller proteins cleaved by proteases, so NS23 or NS34A or NS5A. And these are the structure proteins are released due to that cleavage. So this is important. Why? Well, look at our drugs. NS3A4 protease inhibitor, NS5A inhibitor, NS5B inhibitor. So we're inhibiting everything that allows it to replicate. Now, how can you remember these? There's different things. I always remember the NS3A4A protease inhibitors because they're protease inhibitors and they end in previr, right? You can see the P and the protease. The NS5A inhibitors, NS5A has A in it and it ends in asavir or asvir. So that's how I remember it. And the same thing with the NS5B, it has buvir. So those are ways to remember those and appreciate those. So keep that in mind. So when we talk about hepatitis C, there's 6, there may be a 7th out there. But what you need to appreciate is 75% of the patients in the US will have genotype 1. Now, you must know the genotype before you start therapy because that's going to dictate which drugs you pick. But usually when you talk about the remaining patients, they're going to be 2 or 3. But remember, the treatment is determined by the genotype. So 1A, 1B, 2, 3, 4, 5, or 6. So, and whether the patient has cirrhosis or not, a lot of times that will be indicative of how long or what drugs you use when you treat it. And race can play a role as well. But you can see some of the products. Now, when you look at this, it ends in previr. So you know this is a protease inhibitor. You know that this is an NS5A inhibitor because it's asavir. And NS5A protease inhibitor, NS5A, sofosbuvir, right? This is NS5B. But you can see the different names that are out there. Harvoni was probably the prototypical drug that came out. But when you look at these combos of therapies, these can be used for genotype 1A and 1B in patients with or without cirrhosis. So that's the first thing. Can you use Harvoni in a patient with cirrhosis? And you can. Now, the treatment durations are going to be anywhere from 8 to 12 weeks. But I want you to remember this, cirrhotic patients always require 12 weeks, regardless of the drug of choice. Now, in Caucasians without cirrhosis, there's some 8-week regimens. Usually with African Americans, though, you need to extend it out the full 12 weeks. And then if you're viral free on these viral therapies after a certain amount of time, you're considered cured. But kind of play with this when you look at one. If I ask you a question on a test, which drug is an NS5A inhibitor, kind of play with them, or a protease inhibitor. And let's say I put these 3 selections there where you would say that that's an NS5A inhibitor, that's an NS5A inhibitor, and that is an NS5B inhibitor, and that's a protease inhibitor. So kind of play with those as you go through them. So hepatitis C drugs, so there's your NS5A drugs right there, your inhibitors. And you can see, I'm not going to go through all these together, but you can see where they work in the life cycle. There's your protease inhibitor, so your NS3, 4A, again, these NS5A, A, right? And then your protease inhibitors, P. You get the point. And then your NS5B, those RNA-dependent polymerase inhibitors, B and B. So that's a good way to remember them. So these can be taken with or without food. Now, this is the one exception is the caprevir and the pembrolizumab should be taken with food, but no renal dose adjustments. You do have to appreciate drug-drug interactions. We're not going to go through them. You need to look that up every time. And then common adverse effects, headache, fatigue, and weakness, but they're very tolerable. Now, the U.S. box warning, you do need to make sure that patients with hepatitis C are not co-infected with B. This can lead to reactivation of hepatitis B, and it can destroy the liver, so keep that in mind. But these are very highly effective regimens. They cost money. They're much more affordable, but work with the drug company, work with different organizations to try to get these therapies for your patient. So hepatitis C, the ribavirin, this isn't something we do, but if you have a patient who fails therapy and they have some chronic hepatitis C, this is something that we would use often, but not as much. But this is a guanosine nucleoside analog, and it would be used in combination with interferon for chronic hepatitis C. Now, there may be situations where you'll see ribavirin and interferon pulled back out, but they're few and far between. But one thing about ribavirin is we never use it in patients who have renal insufficiency. So that's something to keep in mind. So that's going to be our discussion. That was quick. Again, these are very detailed discussions that we don't have time to appreciate. So worms, the helmets, let's finish it up with worms. And there's your nematodes, there's your trematodes, and there's your cystodes, and you can see it. The big one you're going to see is nematodes and pinworms. You can get these in the dirt and so on and so forth. So those are the ones that can really cause it. And at night, they come out of the rectum to lay their eggs and go back in, but it can lead to itchiness. And you can take a bendazole, a one-time dose of bendazole. There's different things you can take to try to knock these out, but it's, put tape on the rectum of a child to see if the eggs can be seen in the morning and things like that. Double-sided tape. There's all type of strategies to see, but usually it coincides with itching. So the big one, so the albendazole, that's the one that I would prefer, the albenza, but you do have the mebendazole. They're both effective for treating those nematodes for sure. And albendazole can be used for some cystodes. When we left Africa, we all took a dose of albendazole. Now, the adverse effects, when I took my albendazole for about 6 or 7 hours, I didn't have abdominal pain, but it was just achy. It'd be the best way to put it. I didn't feel good until we got to London. I just felt bad. Now, these are avoided in pregnancy. There are certain situations, you just got to play it out. They use these quite a bit in Africa, but you can see we don't do really prolonged use for the most part in our world. It's a one and done, but you can get some bone marrow suppression and some hepatotoxicities. But yeah, these are your two choices. Usually just a one and done, but these are microtubule inhibitors. So yeah, the worm's gonna die worm. Then you have your over the counter, and this stuff works. Your parental pamawate, it's a Rhesus pinworm medicine. It's oral. This is going to be for nematodes, so those ringworms. But in essence, it paralyzes the worm. And when it does that, when you paralyze a worm, it releases its hold on the GI tract. It's not sucking to it or clamped to it, and you poop it out. So it doesn't have a way to hang on, if you will, while stuff's passing through it. So just think, when you think of Rhesus, or when you think of parental pamawate, think of paralysis, and the worm gets pooped out. But again, anything working the GI tract can potentially cause some GI side effects, and it is a weight-based dosing, and it's nicely written out on the back of the box. Your ivermectin, gosh, I hated all the bad press. They acted like ivermectin would kill people. No, you don't do it in horse paste, but ivermectin has been a lifesaver across the world, and it's been very frustrating because they made it out to be a drug that was extremely dangerous, and that's not true. It's not effective for the coronavirus, and you don't want to take it mixed with the horse paste because you don't know what else is in there. But maybe not in the US, but in the rest of the world, yeah, river blindness and things like that, ivermectin was a cure-all. And I just don't understand why we had so much vilification during the coronavirus. But anyway, we use this for nematodes, so it's a good choice, and it's going to cause an influx of chloride, and again, leads to paralysis and death of the worm. Now, the greater than 10% will have that Mazziotti reaction, and this is going to be fever, headache, dizziness, hypotension. This is the microfilariae killing. Yeah, you can give some steroids or histamines, antihistamines if it happens, no doubt. Clinical pearls avoid in pregnancy, but it does not work in worms caused by the onchocerciasis or the river blindness. But I think I said it was used for river blindness. I can't remember the not river blind. There's one though. Gosh, I'm gonna fact check that right quick because I was under the impression that it did get used for river blindness. Maybe I'm wrong. Fortunately, it's really easy for us in the U.S. though to these drugs to say things because we don't have to worry about this. Anyway, when you talk about river blindness, it is a nematode, and it's transmitted by mosquitoes. And like since we're in Africa, you think about, oh my gosh, I'm worried about malaria. Well, a lot of things are spread by mosquitoes. So anyway, let's just look it up, and I want to see. I thought that it was you could treat it with most patients. Oh, so most likely to see active infection. So maybe just a few people. No, no, I'm sorry. Diethyl carbamazine, DEC, is what they're using. I think if you wanted that, and I'm sure you could use Doxy, just think every Doxy works for everything. So there's a bendazole. The idea that high dose may kill that are mixed reviews. There's the DEC, drug of choice. Doxy may be useful by killing. So, and there it is. So here it is, ivermectin, effective at killing microfilaria, side effect profile similar to DSC, but generally milder. The reappearance of microfilaria faster than with DSC. Does not kill adult worms, but has advantage of single dose therapy. So yeah, I thought that was cool. I apologize. It says does not work on adult worms caused, but yes, it does get those. So any further maturation will be inhibited. So I was thinking, I knew I wasn't crazy. So anyway, you can have so doxycycline, the DEC, the ivermectin, or the albendazole. So those are the things. Anyway, we did talk about this though, the river blindness. I don't think they see it in Cajado. I'm not necessarily, but this is one of the things that Joseph Sancook and I talked about. QFI, we talked about all kinds of stuff. This is stuff we don't see here. But anyway, I didn't mean to get on my soapbox, but I just don't like when drugs like hydroxychloroquine are villainized in ivermectin, and they're made to sound like they're drugs that'll kill you and they're no good for anything, when they're great for patients with arthritis. The hydroxychloroquine, when you have rheumatoid arthritis, ivermectin in other countries does have a big role to play. The praziquantel, so this is infections. These are going to be trematodes and cystodes, but you're going to get increased membrane permeability to calcium, so you get contraction paralysis. The contraindication is ocular cystosarcosis. I've seen a lot of neural cystosarcosis, and it's usually from underfoot port for people coming up from Mexico. But if it's an ocular cystosarcosis, you avoid it because it can lead to irreversible damage of the eyes. But the drug interactions, it is a substrate of the 3A4 isoenzyme, so you need to appreciate that if you're using it. Adverse effects, again, dizziness, malaise, GI upset, and it can exacerbate seizure disorders. But you certainly want to take it with food, but don't chew it. It'll have a bitter taste. How do I know that? Because it says that. I've seen praziquantel used, but I've never taken it myself. But cystosarcosis, now neural cystosarcosis, I've seen over a handful of cases over my 27 years, but every case it was someone who migrated in one way or another, or had recently visited family in Mexico and ate undercooked pork, and that's how it happened. So this is the DEC right there. This is the one I talked about the diethyl carbamazine, and this would be the one for river blindness, but ivermectin too. But again, and there's the treatment of choice for filariasis, and that's what river blindness is the filariasis. But its exact mechanisms unknown, but you can read it. Contraindication, this would be the adult worms. I guess I don't understand this comment either because of the blindness and the severe Misiotti reaction. And we talked about that. That's, the fever and everything, but it's right there. This is what this reaction is right here. So, but I'm going to have to do some looking up on this because there's some things in here. I mean, the slide deck, I updated it, but this one's one that I didn't make updates to. I just need to make sure that I'm in up to date with all this because you don't see it much. Now, I am going to do another screen share. So let's stop the share on this one. And let me pull it up right quick because there's a couple of things I want to show you from Farm Facts. Let me see if I can just share this one. So let me go to infections. So where's the Zoom? Where's the Zoom? Share screen. Which one is it? I'm going to share that screen. Okay, hopefully you can see this. And okay, let's see where we're at. Infections and cancer. Antimicrobials. We talked about these. Metronidazole, we talked about that. So I want to pull some of these up just to take a look. And I'll just kind of scroll through this slowly. So maybe you can read through it. You can pause me and read through it. But again, there's the side effects. But I just want you to look at these. And these are the clinical considerations when we talk about the pharmacology. But these are things you can look at and appreciate. So, but I just want you to get the opportunity to, you can pause it and look through it. I'm going to go through each one of these because I think it gives you a different perspective in your antiviral summary. These are your different medications, HIVs, but I thought it had some other, there's the infographics there. I'm just going to pull them up one at a time, and I'll just, there it is. You can pause it right there. You can read it, but this just gives you some good ideas of what's going on. That's the acyclovir, which we talked about today. A lot of chemotherapeutic agents in here. Drugs used for HIV. This just gives you a way to know nomenclature. I'm not going to go through it. But some of these we went through it quick, and I feel like these might be. If you're interested in this, you can see the website. It's Farm Facts. There's the pyrethroman. There's the praziquantel right there. And that gives you something to look at. Anyway, not much there. So, okay, so that we're going to go ahead and stop with this. This is going to put an end to week 3, lecture 2. We'll pick up with week 4, lecture 1. We went, how long did we go today? We went an hour and 20 minutes, so we'll leave it at that. So anyway, questions, feel free to reach out. I hope that was informative. Didn't go into a lot of detail because it's just not, I don't think it's learner level stuff, but I think you do need to appreciate the nomenclature and just be introduced to the fact that we do have drugs that can cure hepatitis C. We can treat it just for 8 weeks. When do you extend it out to 12 weeks? When do we extend it out to 16 weeks? Those are things you're going to have to massage, but your bigger cities are going to have HIV or hepatitis C clinics. So that's going to make it beneficial for you. But anyway, I hope you enjoyed.